Good evening, all the students present here. We'll be starting with the extended EDIC Part 1 crash course. And the speaker that we have here is Dr. Shraddha Patharkar, ma'am. Ma'am, you can take over. Thank you. And
Yeah,
she will be covering hematological management. All the aspirants, it's going to be a very interactive session. Please type your answers or any queries in your chat box. If necessary, you can also unmute yourself. Thank you.
yeah. We are starting with first case. 55-year-old female, known case of diabetic hypertension (IHD), recent history of receiving painkillers for her backache and generalized weakness. Some antibiotics also she has taken for low-grade fever. Presented with one episodes of GTCS followed by right-sided weakness, altered sensorium since a day to tertiary care hospital, where her MRI brain stroke protocol was done, which was normal. There was no bleed, no infarct. So labs were done suggestive of low platelets of 22,000, hemoglobin of 9, and WBC count was 6,000. There were mildly deranged
No
LFTs.
question. Question is not seen. We couldn't
Uh,
see the question, ma'am.
so can you see the question now?
Yes, ma'am.
Yeah, because I'm in slide share, no, I'm not like nobody can make out anything, so I'm just zooming it.
Sure.
So can
You
you?
can, hi, if you can press this button with the plus sign above the design button, where there is file, home, insert, draw, design. Above that, there is a square with the play button. If you press that, it should come into a screenshot mode. Thank you.
Yeah, but this slideshow mode, it's the button is there, but it's on slideshow only. I was.
Actually, with ma'am, the screen is visible as slideshow only, but we are having the entire thing visible here. So, ma'am, I think you have to drag it and you have to do it.
No, I mean slideshow. Whenever I'm clicking, no, it's every time. I don't know why this is happening.
Yeah.
On slideshow only, I'm clicking, but nobody can see anything. So that's why I have to come out of the slideshow.
கிளம்பு போ எழுந்துரு அங்க
So,
போம்மா
yeah, so we'll start like this only. I hope at least you can read the question. So, is the slide at least visible?
Yes, ma'am, the slides are visible. The line, it is starting with 55-year male,
Yes.
female. So,
So, 55-year-old female, known case of diabetic hypertension and IHD. She had recently she received painkillers for her backache and weakness. She took some antibiotics also for low-grade fever. Presented to tertiary care with one episode of GTCS followed by right-sided weakness and altered sensorium. When we did MRI for her, MRI stroke protocol, that was normal, no infarct, no bleed. Labs were done suggestive of platelet count of 22,000, hemoglobin of 9, and WBC of 6,000. Mildly deranged LFTs were there, creatinine was 2. And we noticed hematuria also after Foley's catheterization, which was non traumatic. Her fever profile was sent, which was negative for malaria and dengue. And the ANA by IFA was sent, that was positive, and we sent the blot also for her. So all are false except plasma exchange with the FFP has a mortality benefit in this case. Low platelet count of less than 30,000 favors the diagnosis of HUS, that is hemolytic uremic syndrome. Low Adams 13 level is a specific test to diagnose TTP, and mixing studies help establish diagnosis of congenital TTP, which is the false one. Can anybody make out what is this case is all about? Hello?
TTP.
Yes. Because see, in hematology, there are only 8 to 10 cases, and this TTP, APLA, all these cases are very favorite topics in EDIC. So, yes, it is TTP, but can you just choose the false statement? All are
False
false.
could be
The true
2.
one, sorry. True one, can you select?
213.
Not
3 also
actually.
correct. Yeah, the one.
All are
2.
false except.
False.
So, the true answer here is plasma exchange with FFP has a mortality benefit in this case.
Okay.
Plasma exchange is
Yeah.
the modality of choice in TTP, and it has a
Okay.
mortality benefit. And the success is quite high when you start it as early as possible. So within 6 hours, you should start it. You don't wait for the results to come. Empirically, you only when clinically you suspect and the lab wise, data wise, you suspect, because this Adams 13 level and all, it takes time to come. And there are many other etiologies where Adams 13 levels will be low. So like in sepsis also the levels will be low, in pregnancy levels will be low. So you cannot, it's not a specific test to diagnose TTP. So and even when you send those level, you cannot wait for the results to come. You start plasma pheresis as early as possible. So the correct answer is plasma exchange with FFP. It has a mortality benefit. And why FFP? Because many a times these are like acquired TTPs, uh, where there will be the production of antibodies against this Adams 13 factor, which will be removed through plasma exchange, and a new Adams 13 will be added through fresh plasma. So the correct answer is plasma exchange with FFP. And always remember,
Yeah.
TTP is also emergency. It's a medical emergency. You need to act faster. So TTP, one of the causes of thrombotic microangiopathy. Can anybody tell me what do you mean by thrombotic microangiopathy? Anybody?
Yeah, let me say something. A thrombotic microangiopathy simply means the platelets, form a platelet thrombus in small vessels. And as a result of that, there is a
Yeah.
microcirculatory
So
failure. There's an organ failure. The brain, kidneys, and other organs, they fail because of poor tissue
yes,
perfusion, because of the microthrombi.
yeah, but there are two important component in this. Patient have will have thrombocytopenia. Despite that, patient will be thrombotic. So there are very few conditions where, despite thrombocytopenia, patient will be thrombotic. And most of these thrombotic microangiopathies cover those conditions. The TTP HUS is one of those. Another other which are other DDs where
HIT,
platelets will be
hit,
low.
hit,
Yes, hit. Okay.
ITP, but ITP no thrombosis.
No, no.
Yeah.
HLH?
No, actually, there will not be any thrombotic tendencies as such, and it's not a.
DIC?
See, in thrombotic microangiopathy, there should be MAHA, that is microangiopathic hemolytic anemia. So that's why I asked. Thrombotic microangiopathy, there should be low platelets. There should be presence of microangiopathic hemolytic anemia, and how you will diagnose
PNH,
that? Uh, PNH, you can label it, but it's not very common. The commonest being TTP, HUS, APLA, catastrophic APLA, DIC. DIC is very common. We know that thrombotic DICs is also there. Early part of sepsis, we have uh, thrombotic DIC. Then HELP syndrome, drug-induced thrombocytopenias. So many other etiologies like post-transfusion purpuras and all. These all things cause thrombocytopenia, but at the same time thrombosis, because the mechanism here will be there will be microangiopathic hemolysis, and because of those breakdown, microthrombi will be formed, and those will block the small vessels. And there are certain disorders like APLA, renal scleroderma crisis and all, where even the larger vessels will be occluded. So you need to know differentials, because these are like very favorite topics. So can you see this slide? Because in this slide, all the essential features of any thrombotic microangiopathy, particularly TTP, they have mentioned. So how to differentiate between TTP and HUS? In TTP is mostly thrombocytopenia is very severe. It's less than 30,000 of platelets. In HUS, most of the times platelets will be higher than 30,000. Uh, while the kidney involvement in TTP will be not that severe. Most of the patients will be non-oligouric and they will not need dialysis. But in HUS, kidneys will be involved more. So creatinine will be more than 3 or so, or patient might need dialysis from the beginning only. But the platelet count will not be that bad in HUS. So these are the two important differentiating features. And why you need to differentiate between TTP and HUS? Because plasma pheresis, plasma exchange helps in TTP, but it is not the treatment modality in HUS. So you need to distinguish between these two. You are getting the points, students?
Yes.
Yeah, and yeah, so 100% low platelets less than 30,000, it is present in 100% of the times in to diagnose TTP. So low platelets should be the one of the criterias. 100% of the times there should be MAHA, that is microangiopathic hemolytic anemia. So the peripheral smear will show schistocytes. Again, schistocytes might be there in DIC, it might be there in HIT also, in catastrophic APLA. But remember, schistocytes quantity, it's always higher in TTP. It's always more than 1%, 1 to 2%. So and LDH, it is also very important component. LDH again, it indicates high LDH indicates your intravascular hemolysis. So all these hemolysis parameters like schistocytes present, LDH high, low haptoglobulin, indirect bilirubin, all these things you can see in your labs. Then 70% of the time CNS involvement will be there, and there will be fluctuating sensorium. Sometimes patient is responding, sometimes patient is irritable. 50% of the times AKI is there. As I told you, in HUS, AKI component is much more important than platelets, significant. And fever will be there in 20%. So you can make out all the 5 components won't be there all the time. So this pentad of TTP won't be there most of the times. It will be there only in 5 to 10%. So you have to diagnose depending upon the first 3 to 4 features which are important. Then ischemic tissue damage due to the microvascular occlusion. Because of this microthrombi, they block the small vessels of the kidney, brain, heart, gut, skin. So all these organs might get involved. So even these patients can present as a MI. These patient can present as a stroke. Depending upon the organ involved. So a renal involvement is again mild, creatinine of less than 2.3. Rarely needs dialysis. Small size vessels are involved. Low Adams 13 again. There are many conditions where Adams 13s will be low, like in sepsis, in pregnancy, in burns trauma. But again, the levels of Adams 13 won't be this low. There will be like when the levels are more than 60%, it is normal. So that rules out your it has a good negative predictive value, so it rules out. But if the level but again Adams 13 is present, it doesn't qualify that patient will have TTP unless the levels are quite low. So if less than 10%, that is also one of the diagnostics. Acquired TTP, most of the cases that we will be having is acquired TTP. Many a times this thienopyridines, clopidogrel, ticlopidin or tirofiban infusions and all, they can cause autoantibodies against this Adams 13, which can lead to TTP. So even these drugs are also one of the common reasons for acquired TTP. And yes, we do mixing study for diagnosis just to see whether it is because of the antibodies present against Adams 13 or the factor deficiency it is there. But congenital is not that common. And many times when congenital TTPs, they present in pregnant women when they are coming for the first time for delivery. So they might develop these pregnancy precipitates TTP. And the classic feature is PT APTT is normal. So they will give you case where your PT APTT is normal. So again, though TTP resembles that of DIC or catastrophic upland all, but again, important differentiating feature is in TTP, PT APTT will be normal. There will be low platelets and there will be schistocytes. These are like important distinguishing features.